The processes that all of these neutrophils can get into the tissue is via the following steps that we are going to talk about. The first step is margination. Now, what you have to know is that margination happens when there is the dilation of vessels. Of course, when we are talking about that, we are talking about postcapillary venules. And when there is dilation, normally these neutrophils and these white blood cells, they marginate along the endothelium. The next step is rolling, and rolling happens and is mediated by adhesion molecules on endothelial cells, and mainly they are selectin molecules. We have two types, P-selectin and E-selectin. Now, P-selectins, P stands for viable plate bodies, and plate stands for plate is a way that I kind of memorized how P-selectins and viable plate bodies are correlated with one another, and also E-selectin that are released in response to inflammatory mediators such as TNF and IL-1. So I want to show you how it all works. So I told you the first step is margination, and margination happens after vasodilation in postcapillary venules, and these leukocytes or neutrophils, they encounter these E-selectins and P-selectins molecules on endothelium, and you have to know that leukocytes grab onto these selectins via sialyl-X receptors, and that causes the rolling procedure. Now let's talk about adhesion. What is adhesion? Now adhesion is molecules that are on the endothelial cells, and they are namely ICAM, also called CD54, and vascular adhesion molecules like VCAM, and also they are called CD106, and they are upregulated both by the TNF and IL-1. So here on this slide, you can see that ICAM, for example, is an adhesion molecule present on the endothelial cell, and that grab onto the B2 integrin present on leukocytes, and that leads to adhesion. Now, there is a disease that is correlated with this, and that's called leukocyte adhesion deficiency, and it's a autosomal recessive defect that cause the defects of integrins or CD18 subunit. Symptoms of that are delayed separation of umbilical cord. And if you think, why is that? So you know that after birth, the umbilical cord is cut off from the mother, and after a while, due to ischemia, the umbilical cord itself usually has to get separated and fall off. But since after ischemia, after any sort of necrosis, there is the acute inflammation happening, and neutrophils get in there to cause the degradation of debris. But since there is no adhesion, there is no integrin, and there is a deficiency in adhesion molecules in the leukocytes, that leads to delayed separation of umbilical cord, because these neutrophils cannot do their job properly. Okay, now increased circulating neutrophils. What you have to know about these symptoms are that is neutrophils normally are hanged on in the in the lung cells, in the lungs, and that happens via the presence of these integrin molecules. Now, since there is defect of integrins, that adds up to the circulating neutrophils, because they are not connected to the integrins in the lung, so they are added up to the circulation of our body. So there is an increased circulating neutrophils. And also bacterial infections recurrence, and that's because of these neutrophils cannot adhere themselves to the tissue parts, and that leads to lack of pus formation, because neutrophils cannot get into the tissue, recurrent bacterial infection without presence of pus. So we talked about adhesion, and the last part is the apoptosis, and that's when these molecules, these neutrophils or leukocytes, they change their shape and they find their way out of the endothelial, and they try to get to the other side, to the interstitium, and that happens via PCAM1 type 4 collagenase. And the last step here is margination, and margination happens when there is chemotaxis and these leukocytes finding the bacterial products, and they attack the bacterial infections. Now let's talk about how phagocytosis happens. So you know that in phagocytosis, macrophages, they make this kind of phagocyting bodies or arms, and they surround the tissue. They make the early phagosome, and this early phagosome, they fuse with these lysosomal vacuoles, and then lysosomes and phagosome fuse together, and release of these lysosomal enzyme leads to degradation of those molecules or maybe cells. A syndrome that is correlated with that is Chediak Higashi syndrome, and that's when there is defect in neutrophil chemostasis and microtubule. It's a polymerization dysfunction, and that causes defect of phagosome lysosome fusion, and that's because of microtubule defect. So in the previous slide, I told you how important this the formation of phagolysosome is, but the defect here is when there is a microtubule defect that does not that defect cause the deformation or the absence of trafficking of these lysosome and formation of phagolysosome in the cell. Clinical features that you can see here are recurrent pyogenic infections because the lysosome cannot fuse with the phagosome, and also neutropenia, partial albinism, and that's because, so you know, in our skin or melanocytes, they produce melanin, but these melanin, because of the defect in microtubule defect, these melanin cannot get or find their way. We cannot traffic these melanin to the part of the tissue to represent it, and that leads to partial albinism. Also, peripheral neuropathy is another clinical feature of that. And a very important thing that I have to mention here is in the peripheral smear of patients with Chediak Higashi syndrome, we can observe a gigantic or giant cytoplasm granules in granulocyte and platelets. You can see here on these slides that these granules that are formed here, and that's because Golgi apparatus is producing all of these granules, but because there is microtubule defect, they cannot traffic these granules to the different parts of the cell, and they accumulate in that part, and that causes the formation of giant cytoplasmic granules in the cell. Now the last step in here is killing and degradation. Killing and degradation happens via two pathways. One of them is oxygen dependent and another one is oxygen independent. Now oxygen dependent pathway is very efficient, and you have to know that how it all happens. We have to talk about biochemistry for that. So what happens here is that oxide is converted to superoxide by NADPH oxidase, and then the superoxide is converted to HTO2 or peroxide by COD or superoxide dismutase, and this superoxide is converted to HOCl or bleach by MPO or myeloproxidase. Now, if there is a defect in these enzymes, there will be a defect in oxygen-dependent procedure or pathway. Now, oxygen-dependent pathway involves production of reactive oxygen or bleach, and diseases associated with defective oxygen-dependent killing are chronic granulomatous disease of childhood, and that's due to defects in the NADPH oxidase, so here, and that leads to lack of superoxide ion, because you know that oxide transferred to superoxide by presence of NADPH, and when there is defect of NADPH oxidase, and then there is a lack of superoxide. Now, That leads to recurrent persistent infections with catalase positive organism. And why is that? Why there is persistent or recurrent infections for the catalase positive organism? That's because there is another way that our cells or our macrophages can make these bleach or these HOCl, and that's when microorganism or microbes they themselves produce the superoxide a little bit, and via catalase they form the we can form bleach. But if a infection is catalase positive, then also the second pathway is defective, and we cannot form HOCl, and that leads to a recurrence of infections that are catalase positive. Example of that are ACE aureus and also PCPCA. And the test for these individuals suffering from deficiency of NADPH deficiency, NADPH oxidase deficiency, is they have NBT test positive. So NBT test for presence of NADPH oxidase. When you produce this test, you can observe that patients with deficiency of NADPH oxidase, they have NBT test positive. So another deficiency that we want to talk about is myeloproxidase deficiency, and that leads to reoccurrence of fungal and infectious diseases. This is when we have the deficiency of myeloproxidase, and you know that for conversion of peroxide to bleach, we need this myeloproxidase. Those individuals with myeloproxidase deficiency, they have NBT test negative, because NBT test for NADPH oxidase, not for the myeloproxidase. So their NADPH oxidase is okay, there is no deficiency there, but what they're defect in is myeloproxidase. All right, now after killing and degradation, we want resolution, and resolution happens via macrophages. You know that there are different phases in acute inflammation, and once neutrophils undergo apoptosis, macrophages predominate. And these macrophages are those kind of cells that phagocytose materials using secondary granules lysosome. And macrophages are kind of managers of acute inflammation, and they come to the tissue, they check what is the next step, and whether they start resolution and healing via IL-10 or TGF-beta, or when they see that there is a still kind of infection in there, they call the neutrophils, and they ask for continuation of acute inflammation via IL-8. Now, that can be abscess formation or chronic inflammation.